This video is on synchronous positive pressure ventilation, or SIPPV, or assisted control PC. In this mode, the baby initiates the breath, and the ventilator controls the pressures. This topic presented by me, Dr. Song Keshba, neonatal specialist. We will review a case scenario to demonstrate the use of SIPPV. The baby, Ahmed, a 33-week-old, 2.6 kilogram baby, has been stabilized on conventional IPPV, and the team decides to transition to SIPPV. We will look at setup, monitoring, and weaning. The answers will be revealed throughout the following slides. This is a brief look at a ventilator screen, which shows the flow, volume, and pressure graphs during ventilation, measured tidal volume per kilogram, and percent of leak spontaneous minute ventilation. SIPPV allows the baby to trigger or initiate each breath, while the ventilator provides the work of breathing. The baby determines the rate of ventilation, and the operator determines the pressures. Key benefits include synchronization with the baby's effort, reduced risk of lung injury, and less need for sedation. When setting up trigger ventilation, a humidifier is set to 39 degrees Celsius to target an airway temperature of 37 degrees Celsius. Initial settings for the Babalog and SLE ventilators are shown here, including flow, mode, trigger sensitivity, inspiratory time, backup rate, PIP, PEEP, and oxygen levels. Preparation involves considering IV caffeine for babies under 34 weeks and discontinuing sedation. Once connected, check oxygen saturation, adequate chest movement with a tidal volume of 4 to 6 milliliters per kilogram, and synchrony between the ventilator and baby. A blood gas check should be performed within 30 minutes, with specific targets for PaO2, PaCO2, and pH depending on the baby's age. For improving oxygenation, increase FiO2, rule out pneumothorax, increase PIP or PEEP, and increase inspiratory time to a maximum of 0.4 seconds. To decrease PaCO2, rule out pneumothorax, increase PIP, and check for baby triggering. If the baby is not triggering, shorten the inspiratory time or increase the backup rate. For low PaCO2, decrease PIP or decrease the backup rate. If the baby is vigorous and hypocapnic, consider transferring to SIMV at a rate of 20 or more breaths per minute. Management of asynchrony starts with checking ETT patency and inspiratory time. Shorten TINSP to 0.3 seconds if the baby exhales against the ventilator. Reduce the backup rate if it is too high. Check for water condensation, and consider a morphine bolus if necessary. If all else fails, continuous sedation and reverting to SIMV may be needed. Autocycling is false triggering, often caused by water droplets or excessive ETT leaks. Confirm by observation, empty water condensation, and decrease trigger sensitivity, or consider a wider ETT if the leak is excessive. Hourly nursing observations include the set backup rate, the baby's own respiratory rate, tidal volume, and minute ventilation. If an alarm sounds, check for synchrony, excessive water droplets in tubing, blocked tube, or excessive inspiratory time via the flow graph, and disconnections. Continuous SpO2 monitoring and timely blood gas checks are essential. Sedation is usually unnecessary, but morphine can be used if the baby fights the ventilator. Weaning from SIPPV begins when the baby is triggering above the set rate and saturating on an FiO2 of less than 0.3. The first step is to reduce PIP by 1 to 2 centimeters of water per step. Next, confirm regular, effortless breathing with acceptable blood gases and oximetry. The extubation point is when the PIP reaches 14 to 16 centimeters of water, depending on the baby's size. Finally, assess for NCPAP or high flow requirements by checking for chest recessions, spontaneous minute ventilation, and breathing regularity. Key reminders include checking blood gas within 30 minutes, monitoring SpO2 continuously, considering caffeine for babies under 34 weeks, and considering extubation at a PIP of 14 to 16 centimeters of water. Do not use muscle relaxants unless absolutely necessary. Do not assume fighting is behavioral, and check for asynchrony first. If a trigger rate appears above 80 per minute, confirm it by observation. If muscle relaxants are needed, revert to conventional ventilation.